All right, we are going to do a kind of a 12 and 15 lead review here. This is something I've been working on over the past few weeks, trying to figure out what to do and how to help you guys out. So bear with me on this. I'm in the process of creating it all. So yeah, here we go. Let's talk about this 12 lead and 15 lead. This is not a totally basic review of it all, but we're not going to get super in depth. Hopefully this will help clear things up. Of course, any questions or whatever, I'm more than happy to answer. We're going to look at some anatomy and blood flow through the heart, electrode placement, some terminology, some conduction system disturbances, STEMI with left bundle branch block, some STEMI mimics, and then some other oddities with EKGs or ECGs, either one. So let's do a quick review here of the heart and coronary arteries. So the left main coronary artery has two branches, the left anterior descending and the left circumflex. The left anterior descending supplies blood to the bundle of His, the right bundle branch, and the left anterior fascicle, and that's all part of the electrical system of the heart. It also delivers blood to 2/3 of the septum, that goes down the middle of your heart, and the left anterior ventricle of the heart. The left circumflex artery supplies blood to the left lateral ventricle and then part of the left posterior ventricle. And the right coronary artery, that's in most of our patients, the right coronary artery is the big boy. It's the dominant one. And keep in mind, with all of these, every person is a little bit different, so it might not supply completely the exact same in every person. But for a majority, this is what it supplies. Each artery supplies these areas. So the right coronary artery hits the SA and the AV nodes and supplies blood flow to that part of the electrical system. The right atrium, 1/3 of the septum, the right ventricle, part of the left inferior ventricle, and then the posterior of the left ventricle. All right, here's a nice little photo for us that shows this right coronary artery. That's our big boy. This is looking from the front of the heart. We're hitting our SA and the AV nodes right up in here, and then it moves on to the right, hits the septum, and moves around back. Hits that right ventricle, hits the inferior part, and if you can tell there, it loops around the back and it hits the posterior part of the heart as well. So if you've got a blockage down here, it could hit the posterior and that inferior wall, and your right ventricle still could be functioning. The left main coronary artery is right up here, and then it quickly divides off into two different branches. The left circumflex that comes over here and hits that lateral side, and then the anterior descending that supplies a lot of blood flow for their electrical system, and then the septum and the anterior part of that left ventricle. Hope that kind of helps clear it up and makes it easier to remember. The SA node is right up here, near that atrium, I should say. Electrical current comes down through these different electrical pathways and hits the AV node, and then is spread out here through the AV bundle to the Purkinje fibers on each ventricle. The intrinsic rate for the SA node, 60 to 100. That's normal. That's what our heart beats at. You and I, just normal people. If the SA node for whatever reason fails, then the AV node there in that AV junction has a intrinsic rate of 40 to 60. And on those, you'll lose your P wave. If it's a junctional rhythm, that means it's originating right here. You'll lose your P wave, and then your rate will also be slower, usually 40 to 60. And then if both of those have failed, as is the case with VTAC and stuff like that, that Purkinje network has an intrinsic rate of 20 to 40, and so it can beat by itself at a rate of 20 to 40 if it has to. It's not going to keep up for super long, but it is possible. People that That's when you get those. Yeah, we'll just leave it at that. Electrode placement, some basic principles. Shave the body hair if necessary. These electrodes don't like to stick to hair very well. Rub the site briskly with a dry gauze pad or a towel to reduce artifact and help adhesion issues. So if you can dry off the patient, even if they're not super sweaty, if you get some of those dead skin flakes off there, those electrodes are going to stick a lot better and give you a better quality EKG to look at. And you're really just doing yourself a favor whenever you rub the patient down before you put the electrode on. And then based on what brand of electrode you're using, it is a good idea to put those on, attach the electrode to the cable before you put it on the patient's skin. And of course, always confirm your correct location. So our limb leads, we have 4 of them. You got your right arm, left leg, right leg. You can put them up here on the shoulders and out on the lower abdomen. The farther you can get it away, if you can put it down on the legs and up here on the biceps or something like that, that is going to give you the most accurate reading. So the farther you can get away from the heart, the better. Einthoven, what was his first name? Willem Einthoven had a theory that every time the heart contracts, electrical energy is emitted. And then he was able to prove that theory. So lead 1, if you're looking at your standard 12 lead, lead 1 is reading across the chest, going straight across the chest, is moving perpendicular to someone who's standing up, across the right and left arms. Lead 2 is reading from the right arm to the left leg, so it's moving there. And then lead 3 runs between the left arm and the left leg. So if you keep all that in mind, the energy that it is reading and registering is moving from negative to positive. So that is rather important. The augmented leads are AVL, AVR, and AVF, are a computer-generated reading that what it does, the monitor that we have, takes like an average between say the left arm and the left leg, and then finds the middle, and then does your AVR as your positive. So whenever you look at those, again, it's traveling from negative over here to positive, and that electricity is, and that's how it's being read. So AVR reads from the left side up to that right shoulder. AVL reads from the right side up to the left shoulder, and then AVF leads from the top of the chest down, pretty much straight down through the navel area. And a lot of that's just good to know, like what you're looking at. Our precordial leads, V1 through V9, they are unipolar. They do not lead across anything that, like lead 1, 2, and 3, AVR, AVL, AVF, read across the chest in a certain direction. The precordial leads do not lead across the chest, they read into the chest. So that they all point into the chest. They are calculated against a certain point. The Wilson central terminal is what they're all calculated on based on the computer. And they all look, like I said, straight in, whereas 1, 2, 3, AVL, AVL, or AVF look across. So lead placement, we need to make sure we are placing our leads correctly. V1 goes in the 4th intercostal space just on the right side of the sternum. V2 goes on the left side of the sternum at the same level. Those leads should be an inch and a half apart, something like that. They should not be 6 inches apart. They should not be on top of each other. They should be on either side of that sternum. And those 2 leads are looking at the ventricular septum whenever you print off a 12 lead. V3 and V4, or I should say, let's go to V4, goes in the 5th intercostal space, mid-clavicular line, right up here where our clavicle is, just straight down, 5th intercostal space. that is looking at the anterior wall of the left ventricle, and then we place V3 between V2 and V4, so just split the difference there and put V3 there. V6 will go in the mid-axillary line, and is going to be in that fifth intercostal space as well. And then it is looking at the left, or the lateral wall of that left ventricle. That's supplied by the left circumflex artery. And then V5 will go between V4 and V6 in that anterior axillary line. Again, fifth intercostal space. And it is also looking at that lateral wall. So V1 and V2 are looking at the septum. V3 and V4 are looking at the anterior wall of the left ventricle. And then V5 and V6 are looking at that lateral wall. Right-sided, we'll touch on that. Your V1 and V2 are the same. We don't move those. They still look at the ventricular septum. V3, V4, V5, and V6 are going to be a mirror image of the left side, except you just put them on the right side. And they all look at the right ventricle. So they are used to evaluate the electrical activity of the right ventricle, of course. And what we do, and what I will recommend to you, I don't put V3, 5, and 6 on. I take my 12 lead, normal 12 lead, with V1 through V6. Then I will switch V4, take it off, and put it over on the right side. Underneath. It's going to be fifth intercostal space, mid-clavicular on the right side. And that gives me V4R. And that way I can see my right ventricle. That's going to be your most common way to do a right-sided EKG, is just moving V4R over to see if there's anything. And when you're looking at that on the 12 lead, you should still see nice P, QRS, T wave, all that will look just the same. If you see ST elevation in V4R, then it means there is right ventricular infarct there. 15 lead for the posterior here. It looks at the left ventricle and the posterior wall of that left ventricle. So you can move 3 precordial leads to the back. You got V7, V8, and V9. And you're, again, following around that fifth intercostal space, just like in the front. You'll put V8 on first, and it's going to go mid-scapular, just below that shoulder blade, if you'll attach it there. And then V9 will go just on the left side of the spine. And then V7 you can put between V6 and V8 if you need to. But all 3 of those look at the posterior wall. For me, and I will say the way I do it, when I'm doing a 15 lead, okay, let's talk about when to do a 15 lead. So I'm running, say, a 65-year-old female, chest pain, left shoulder pain, nausea, vomiting, typical cardiac workup. I shoot a 12 lead, look at everything. 12 lead looks good, no ST elevation, nothing crazy, but it just, this patient has a higher increased risk of it being a cardiac event. I'm going to go ahead and do a 15 lead just to rule out and give me a better picture. So, what do? Move V4R over, like we talked about. Hit my V4R there, and then I do V8 right here, below the shoulder blade, and then V9 just on the left side of the spine. V4R, V8, and V9, and the electrodes I use on that is V4, V5, and V6. They're all labeled. V4, V5, V6. I move over to V4R, V8, and V9. Turn off my 12 lead, look at it. It's going to show up just the same. Do I have any ST elevation? If I have ST elevation there, then I know it's posterior walls involved, right side's involved, whatever it is. Also, label that on your 12 lead. Scratch off V4, put V4R. Scratch off V5, put V8. Scratch out V6, put V9. And that way you don't forget which, it helps to label everything and make sure you're keeping that all straight. of your labeling. Okie dokie. If you want to do an 18 lead, have at it. You just take off V1 through V6 after you do a regular old 12 lead, and then you move it over to your right side, and then V7 through V9. Don't really recommend it, but if you want to do it, have at it. I would just say any patient that you run who you think might be cardiac and their 12 lead looks okay, do a 15 lead on them. And then that will help you prove either that it is cardiac or is not cardiac. Don't be afraid to do a 15 lead. It's extra 3 electrodes, doesn't take but 30 seconds. Have the patient lean forward, slap a couple stickers on their back, and hit the button. Good to go. Some things to keep in mind with the monitor. Whenever you're in monitor mode, whenever you first turn on your monitor, it defaults into that monitor mode usually. And it's used for rhythm interpretation, looking at your rate. Is it regular? All that fun stuff, simple stuff. It has a bunch of electronic filters that help remove artifact, and it skews the shape of the ST segment, T wave. It doesn't capture quite as much electrical activity. It's filtered quite a bit. So don't try to diagnose any sort of crazy ST elevation, ST depression, pulmonary embolism, anything like that. Don't try to interpret that from just printing out a monitor strip. Get that 12 lead. It switches over whenever you hit 12 lead and prints off a 12 lead. It switches over to the diagnostic mode. It doesn't filter out anything. That's why you get a lot of squiggly lines, a lot of artifact, a lot more likelihood to have artifact because it's not filtering it out. It's much more sensitive, and it won't skew those ST segments and that T wave. So don't trust your monitor mode for anything other than the rate, regularity, and that's really about all you can trust from that monitor mode. Even your P waves and stuff can change. All that stuff can change once you do a true 12 lead and it switches over to that diagnostic mode. So here's just kind of something to keep in mind. On PVCs, you need to know if they're unifocal or are they multifocal. Is it the same spot in the ventricles that is sending these electrical impulses? If it is, then they'll have the same shape on every time. Every time you see that, like here on the left, every time you see that ectopic beat, it will be the same morphology and same shape. And that just means it's coming from the same spot. So it's good to document that. If it's multifocal, and it's coming from different parts of the ventricles, they'll have different shapes, they'll look differently on the EKG. And then also you need to figure out, are those beats perfusing? Go ahead and grab their wrists, get a radial pulse on them, watch the monitor. Whenever one of these PVCs pop up, you can do the same thing with PJCs, PACs, the whole 9 yards. You want to know, is that a good beat and is it actually perfusing the heart? Or is it perfusing the body? Do you feel a pulse with that whenever it pops up on the monitor? It's important, because if they're throwing a lot of PVCs, then maybe their underlying regular rate isn't very high, and they might not be perfusing the body well enough. So you need to know if those beats are perfusing or not. Some things to keep in mind. 2 or more PVCs together are couplet PVCs. 3 or more PVCs that occur in a row are known as salvos or a run of VTAC, if the rate's over 100. But those are known as salvos or VTAC if there's 3 or more PVCs in a row. If you are getting PVCs every other beat, then it's bigeminy. And then if you're getting PVCs every 3rd beat, it's trigeminy. And this doesn't go just for PVCs. It goes as well for PJCs, PACs, all those funny beats. Just some stuff to keep in mind that you want to be able to document and pass along to your physicians that you're dealing with. Okay, let's look at some AV blocks real quickly, just a review on these. 2nd degree type 1, Mobitz type 1, the old Winky Bock. Occurs when there's an interruption in impulse conduction, occurs within the AV node, bundle of his, or the Precordial system. Somewhere there's a little bit of a blockage there. And what we're looking for is that going, gone. You know, like right here, you've got a good P wave, and then your QRS, and then it kind of gets a little bit longer, higher PR interval, and continues to lengthen out some, and then it ends up dropping a beat. And that is going to be the going, gone, and that is a Winky Bock. Second degree, type 1. And you want to print a 12 lead out to diagnose that for sure. Second degree, type 2, occurs when there's several impulses that cannot continue. This is a really severe version of it in the picture here, but a lot of times, you know, they might have 5 or 6 regular beats, and then it just drops 1 beat or something like that. It's an intermittent block, so you'll have P waves that show up every time, just right on schedule. You know, there's no lengthening PR interval like in the type 1, but just occasionally just drops a beat. And you still got a good P wave before it. Third degree block. Everybody's just kind of doing their own thing. You got your QRS that's going at 1 rate, and then your P wave, which is going at a 2nd rate. Usually if you map those out though, your P waves happen every so often, very regular, and then your QRS is also very regular. They just don't match up, and it might be at a different speed, but they don't match up, and they're each kind of doing their own thing. Usually the secondary pacemaker is junctional or possibly ventricular. If it is ventricular in rhythm, then you know you'll have that wide QRS greater than 0.12. Junctional though, that QRS rhythm will be narrow, less than 0.12. So that's third degree block. The axis, and determining the QRS axis using the quadrant system. And what is an axis? Does it not? Okay, no, I deleted that slide. So what is the axis? So going back to Einthoven's theory that whenever the heart beats, it emits an electrical signal. That is true. And what the axis does is finds out, it like averages out all those tiny electrical impulses and gives you an average of what direction is all this electricity moving in. For most people, it is moving in a relatively downward and leftward position, direction, I should say. So for most people, you know, the right atrium and the left atrium, you know, fire, and that's up at the top of the heart, and then the electrical impulse travels down through the heart and is moving in a leftward and downward direction there. So that's for most people. Let's kind of get our... the way I do axis deviation and thinking of axis is I put up my 2 thumbs, got both thumbs out in front of me. All right, I'm looking at, once I print off my 12 lead, I look at lead 1 and AVF. If I have both thumbs up, I know I'm good. Normal axis, both thumbs up, doing good. If, okay, so you know you got lead 1 over here in your left column of your 12 lead, and then AVF's in your second column on your 12 lead. So lead 1 is represented by my left thumb, lead AVF is represented by my right thumb. So I have those two. So if they're both up, normal axis. If my AVF is a negative, mostly negative deflection, then I flip that right thumb over, and my left thumb is still upright. That means I have left axis deviation. All right, left is up, that means left axis deviation. It also corresponds and means that if you have left axis deviation, you have a left anterior fascicular block in that electrical conduction system. Just so you know. All right, we go back to both thumbs up. If that lead 1 is a mostly negative deflection. We flip that left thumb over and it's now negative. So our right thumb is nice and positive here. That means we have right axis deviation. So whichever thumb is up means you have deviation in that direction, unless they're both up, which is good. So right thumb up, left thumb down means right axis deviation. Means we also have a left posterior fascicular block. That part of the electrical conduction system is blocked if it causes that right axis deviation and that right thumb is up. Now, if you look at it, at your 12 lead, and both lead 1 and AVF are mostly negative deflection, you get both thumbs down, and that's not a good thing. That is extreme right axis deviation, and that is very, very indicative of it being ventricular tachycardia. And so you will treat accordingly. But so both thumbs down is extreme right axis deviation. Very, very indicative of ventricular tachycardia. I hope that kind of helps clear up axis deviation and what it kind of portrays to. We'll kind of get into the fascicular blocks here in a little bit, but just so you know, left axis deviation equals left anterior fascicular block. Right axis deviation is a left posterior fascicular block, and then extreme right axis deviation. And you know, both lead 1 and AVL are negative, means VTAC. The QRS axis, so that average electrical flow through the body, always moves towards hypertrophy just because it generates more electricity and requires more electricity, that big part of the muscle. And the QRS axis also moves away from infarction because it doesn't produce or use electrical activity if it's infarcted tissue. So, kind of helps. Just a little fun fact for you. So some pre-excitation. Pre-excitation. Yep. Early depolarization of the ventricle tissue due to the presence of an accessory pathway, and that is going to be usually the bundle of Kent. They have a couple names for it. It's called Wolff-Parkinson-White syndrome or Longenong-Levine syndrome. You get that, and this is, you get a delta wave with it. So instead of the nice smooth or nice sharp QRS rhythm, you're looking at this delta wave. So it's like a gentle upsloping that goes into that R wave there, instead of a normal QRS that's nice and sharp. Review some 12 leads, look at this, and be familiar with it. If you are running something like that, a lot of times they know that, hey, I've got WPW. Okay, not a big deal, just so you know. Avoid adenosine if they're in a tachycardic rhythm. It can increase that heart rate even farther because of those accessory pathways. It does not. So with adenosine, you know, it blocks the electrical impulses through the AV node. And if they've already got this accessory pathway that lets the electrical impulses bypass that, adenosine's not going to help anything, and it can worsen things. So try to avoid adenosine if they have a history of WPW. Of course, follow local protocol. Right bundle branch block in this wonderful 12 lead. You have a QRS greater than 0.12, so 3 small blocks. And you have terminal R wave in lead V1. So whenever I go to diagnose left and right bundle branch blocks, and I am looking at V1, every time, V1. If I have a terminal R wave in V1, that means it is a right bundle branch block. That and my QRS is greater than 0.12. If your QRS is less than 0.12 and you have that terminal R wave, then it could be like an incomplete bundle branch block. But greater than 0.12 and you get that terminal R wave in lead V1. Right bundle branch block. If you look at normal 12 lead EKG, V1 will not really have an R wave. It's pretty much all a negative deflection and just have that nice S wave there. So if you have that R wave, that is the indicative, that is that right bundle branch, and you get that little rabbit ears that you want to call it, or whatever. Yeah, terminal R wave, lead V1. Left bundle branch block. So with left bundle branch block, it is going to be that anterior fascicle that we talked about and the posterior fascicle. Both of those are blocked off, so electrical can't get through there. And when both of those are blocked off, that is what is a complete left bundle branch block. So with that, we get our QRS greater than 0.12, 3 small blocks. And again, we're looking in lead V1. And there is a terminal S wave in V1. So the last wave before your ST segment is a S wave. You can use turn signal method. It's the same thing. If you haven't heard of turn signal, look it up in your book. It is the same thing. But you get the S wave in lead V1, big L S wave, and that is indicative of a left bundle branch block. Whereas if it's positive there, you got that terminal R wave, that means it is going to be a right bundle branch block. You'll still have the S wave, but it's not the last wave terminal. That's what terminal means. Okay? Maybe that makes things a little easier for that. The fascicular blocks and the hemiblocks. The anterior fascicular block. Remember how we talked about with our thumbs? So put both thumbs out in front of us. Look at this 12 lead. We have lead 1 over in our left-hand column. Lead AVF in our second column down there at the bottom. So remember what we said, both thumbs up. If they're both positive deflections, that's a good thing. That means all is normal, no axis deviation, no fascicular blocks, good to go. In this one, lead 1, our left thumb, is positive, so we'll keep that thumb up. And lead AVF, our right thumb, is going to be negative, so we'll flip that thumb over. So, got that left thumb up. What's that mean? It means left axis deviation and left anterior fascicular block. It's the easy way to diagnose it right there. Got that thumb up, boom, left anterior fascicular block. Easy as that. Posterior fascicular block. So we go right back, and you can read this QR complexes in lead 2, 3, and AVF, and then RS complex in lead 1. That's what I'm saying, just dumbing it down for us and making it simpler for us to remember. So both thumbs up in this 12 lead. Lead 1 is mostly a negative deflection there, so we'll flip that thumb over. Lead AVF is mostly a positive deflection, so we'll keep that thumb up. And we got a right thumb up, so what's that mean? It means right axis deviation and the left posterior fascicular block. All right? That makes sense, hopefully, for everybody. And now if we have both of those fascicles blocked, like I said, that means it's a complete left bundle branch block. That's when we look over in V1 for that terminal S wave and wider than 0.12. All right? A bifascicular block is a right bundle branch block with either anterior or posterior left-sided block. So we look over in V1, greater than 0.12, the QRS complex is greater than 0.12, and we have a terminal R wave there. Terminal R wave. So that means it is a right bundle branch block. All right. So then we get out our thumbs, looking at lead 1 and lead AVF. Lead 1 is positive, lead AVF is negative. So we leave our thumb up for left, our left thumb up, and our right thumb is down. So lead 1, left thumb up means left axis deviation, means left anterior fascicular block in this 12 lead. So this is a bifascicular block. This is all good stuff to know. We don't treat fascicular blocks and bundle branch blocks and stuff. We don't treat that in EMS. That's just, this is all good to know stuff. Helps you with your education, being more diligent and smarter, I guess. All right, trifascicular block. So Bifascicular block, you have to have a right bundle branch, and then you either have to have an anterior or posterior hemiblock on that left side. Okay, so either AVF or lead 1, along with that right bundle branch. All right, trifascicular block. Most common that you'll see, you have to have a right bundle branch. Got to have it. So we look over V1. Got that terminal R wave there. Yep. Greater than 0.12 is our QRS duration. Yep. Even got a little bit of rabbit ears there. So we hit that right bundle branch. Got that. Left anterior fascicular block. So we go back to lead 1 and AVF with our good old thumb method. Lead 1 is positive, so that means lead 1 is positive, so that means left axis deviation and left anterior fascicle block. And then, to be considered a trifascicular block, you must also add either a first or second degree AV block. All right? So if we start looking here, we're looking for a nice P wave. We got P wave there. Got P waves there, yep. But it's greater than 0.2, so we have a first degree block. So we got a right bundle branch block. We have a first degree AV block. We have a left anterior fascicle block. See there, we're looking through those two. All three of those, and it could be a posterior fascicular block or anterior, either one. But all three of those combined equal a trifascicular block. You have to have all three of those. Right bundle branch for sure, either left anterior fascicle block or left posterior fascicle block, and then a first or second degree block to go with it. All three of those equal trifascicular block. And this means it's a sick heart. It really is. If you've got that many different conduction systems blocked, it's not a good thing. You could be looking at, pacemaker or something like that needs to be put in place. They have a sick heart. They really do. Their electrical system is sick. And so if you see all that, keep in mind, hey, this guy's got a sick heart, or girl. We might want to keep that in mind. In case things go south here, we already kind of know that this guy's got a bad heart. So I just want to be very astute in watching my patient, just in case things go south. I'm already kind of prepared for it because it's a sick heart. Okay? Hope that helps. All right. Let's look at some wide complex tachycardia. VTach versus SVT. It's always kind of hard, but we'll try to look at it here a little bit. So, VTach. What did we say very early on about checking our axis? If a majority of the electrical flow in the heart is moving towards the right shoulder. Okay, yep. Let me go back. I don't want to lose anybody here. So, a majority of the electrical activity in the heart is moving towards the right shoulder. It gives us extreme right axis deviation. So our lead 1 and AVF will both be negative using our thumb method. Both of them negative. Both thumbs down. That means the direction of electrical activity is moving towards that right shoulder. And what does that mean? So it means that the electrical activity in the heart is not originating up in that right atrium. Like, imagine this nice chart here with a picture of a heart behind it, and that kind of shows you. So up here would be your atrium, say right atrium, right ventricle, left ventricle. And with most normal people, the electrical impulse starts up here and then moves down through the ventricles. Whenever we are in extreme right axis deviation, both thumbs down, majority of electrical activity is moving from here towards that right shoulder. That means those beats and heart rhythm is originating somewhere in the ventricles and then moving back up and like retrograde up through the atrium. So that is going to be VTach, and that's why you get extreme right axis deviation, is because that electrical activity is moving backwards through everything. Hopefully you're able to follow along with that. I didn't make it too complicated. Okay, so you get extreme right axis deviation. Whenever you have extreme right axis deviation, you'll have an upright QRS and AVR. And by this time in y'all's program, you should be looking at 12 leads on a regular basis. You should know what normal looks like. And in a normal 12 lead with looking at AVR, it's a negative deflection. It looks kind of opposite of all the rest of them. So if you see a QRS complex in AVR that looks like a normal, regular heartbeat, that's not a good thing. That means electrical activity is moving opposite. Because remember the view that you're seeing with AVR. Let's look at it. I should have put those down in there. Where's it at? Is that it? Nope, nope. AVR. Yep, here we go. So AVR, remember the view that it shows you is towards the right shoulder. So if you have a positive deflection there and it shows that electrical activity is moving towards AVR, that means that, of course, it's not originating in the atrium. All right? Where are we at? Okay, so got that extreme right axis deviation. A very wide QRS, greater than 0.14 usually. 0.12, 0.14, either one of those, is going to have a really wide QRS duration. And then positive or negative concordance in those precordial leads. So whenever you take your 12 lead, if all QRS complexes are pointing in the same direction, either positive or negative, that is another indicator that it is VTAC, not SVT. And then, of course, if with SVT, if it's narrow, the QRS complex is less than 0.12, if you can see P waves, that's your gold standard right there. If you see a P wave, you know it's SVT, and it matches up with every QRS. You know it's SVT, and it's not VTAC. But all three of these things here are indicative that it is VTAC. So let's look at a couple of these. So what do we have here? It's kind of hard on this top one. Do we have extreme right axis deviation? This is looking at AVR. These are upright, positive deflection. So that means electricity is moving towards that right shoulder. It means it's originating somewhere down the ventricles, usually. So that's leading us towards VTAC. Can we see P waves anywhere? They could be buried someplace in those rhythms, but you can't discern a P wave. So that makes you think that it might be VTAC. What is our QRS duration? How wide is this? It's kind of hard to make out exactly because it kind of varies a little bit. But we're like 1, 2, 3, maybe 4 blocks, 3 or 4 blocks. So it's pretty wide. And then looking over in our precordial leads as well, they all kind of point downward. They're more pointy on the bottom side there. All of that is indicative that it is a VTAC rhythm. All right? And yeah, all those are indicative that it is VTAC. All right, this bottom one, let's look at it. So let's look at AVR. We have a negative deflection here. Okay, so that means that most of the electrical activity is not moving towards that right shoulder. It is moving someplace else. Looks like AVL. Moving towards that. It's pretty upright. But that's not indicative of VTAC. Can we make out P waves anywhere? Not really. I mean, they're kind of buried maybe in there. It's kind of hard to tell. What is our QRS duration? How wide is this bad boy? Let's look over here in V1. Okay, we got 1, 2, 3, possibly. So it's about 0.12 is our QRS duration. And then do our precordial leads all point in the same direction? So we have mostly negative there, negative there, and more pointy there, negative. Oh, but then 5 and 6, we have positive deflections, and they're really pointy upwards. Okay, so all of that leads us with AVR being a negative deflection. Precordial leads are, they end up pointing at each other. They don't all point in the same direction. And then it is 0.12, so it's about right there. All of that is leaning towards possibly being SVT instead of VTAC. Now, lack of P waves, we can't prove it's VTAC, or we can't prove it's SVT because we can't actually make out P waves and know for 100% sure. But the rest of our stuff here leads us to have a strong suspicion that it is SVT instead of VTAC. So what's this all mean? So at the end of the day, if you can't prove it's SVT, you're going to treat it as VTAC. So what's our treatment for SVT? Adenosine, cardioversion, all that fun stuff. If we can prove it's SVT, we hit them with 6 milligrams or 12 milligrams of adenosine, 100 joules, 50 joules, whatever it is for SVT, based on all your morphology. And then with VTAC, our treatment is amiodarone, defibrillation, those good things. So if you cannot prove that it is SVT, then treat it as VTAC if you can't prove it's SVT. You can attempt to do a synchronized cardioversion. If your monitor will sync up, you can try to do that. 100 joules is a good place to start on that. According to HA, if it's wide and regular, then attempt synchronized cardioversion first. If it is wide and irregular, then you defibrillate first, okay? And you hit them at 200 joules, 360, whatever the monitor manufacturer recommends. And then you hit them with amiodarone, according to AHA, 150 milligrams over 10 minutes first. So, if in doubt about, and you can't prove that it's SVT, treat them with VTAC. If it's wide and regular, synchronized cardioversion. If for whatever reason it won't sync up, go ahead and defibrillate, and then amiodarone as well to try to prevent them from going back into that. Now, if you can prove, and you have those narrow complexes and good P waves, all that fun stuff, and you can prove that it is SVT, of course use adenosine first, or cardioversion if they're really unstable. All right, let's look at some other cardiovascular conditions. Benign early repolarization. It is a normal variant. It is genetic. It can cause some ST segment elevation. It looks different than with a STEMI. The ST segment elevation will look a little different. Have a J or a fishhook appearance at the J point, and then they'll have concave ST segment versus with a STEMI you have convex. And I'll show you here in a second. And then there's changes in the left precordial leads and or the inferior leads. So let's look at this. You do have, this is in the inferior leads here, 2, 3 AVF. You do have ST elevation off the baseline here. So we look at our J point, which is where that QRS meets up, and it is elevated, but it looks like a fish hook here, and it is concave. It is a negative, looks like concave, whereas with STEMI it's going to be convex and it'll go up like that. Hope that helps. So this is benign early repolarization syndrome. It's a genetic thing. So you do have elevation. Let's see, where all we got elevation? 2, 3, AVF, maybe. It's not really enough to categorize it. Then you have, I won't call that. But you do have elevation over here in V4 and V5. And maybe a smidge there in V6. But like we said, it's a J or fishhook appearance, and it is concave. It's down and looks like kind of a cave versus being convex that goes up with STEMIs. So it looks a little different. It's kind of a STEMI mimicker, but don't get confused by that. Pericarditis. And we're covering over some STEMI mimics here that could fool us, so we don't want to fall for these traps of these pesky old 12 leads. So pericarditis, patient will present with positional chest pain that's worse whenever they lay flat usually. It is a sharp chest pain. They'll have shortness of breath, and there's usually a history of recent infection or fever. You don't really have to have that, but all of those things should clue you in that it is, something other than a STEMI. So you look at those, and then, or you get your history there. Sharp chest pain by itself should clue you in that it's something other than a STEMI or a blockage in the heart. Chest pain with a blockage in the heart is usually a dull ache or pressure or something like that. It's not usually sharp, and it's definitely not positional. So it is characterized by diffuse ST segment elevation and a depressed PR segment in our 12 lead. So we have, looking at this, we look at over our 12 lead. All right, we've got, and the way I look at 12 leads is I just start at the top, work my way down, just kind of back and forth. And then if I see anything funky or wonky, then I'll go into my ICL leads of, inferior septal leads, anterior leads are V3, V4, and then lateral leads are V5, V6, 1, and AVL. Review that in the book if you're not sure on the ICL leads or how to group all these together. But yeah, you should know how to group them and what each one means. So let's look here. Lead 1, maybe smidge elevation. Lead 2, definitely got some elevation. Lead 3, nothing. AVR, of course, should be negative like that, like we see. AVL, nothing. AVF, nah, not really. V1, yes, we have elevation there. V2, yes. V3, yes. V4, yes. V5, yes. V6, yes. So we have elevation in all of our septal leads, our anterior leads, our lateral leads, except for AVL. We have elevation everywhere else, and also over here in this inferior lead. So all of these things combined, plus a good history of knowing it's sharp chest pain, it is positional chest pain, or whatever, leads us to think it is something other than a blockage in the heart of a STEMI. Don't fall for that. And also, it does look a little bit different. It does have a relatively concave appearance here with our ST elevation that we're looking at. So it does look a little bit different. So some non-cardiac causes of EKG or ECG abnormalities. 12 leads can kind of show you a lot of different stuff. Some pulmonary embolisms, acute intracranial hemorrhage, electrolyte abnormalities, and then genetic disorders that affect the heart. So pulmonary embolism is kind of a fun one to do if it'll show up. S1Q3T3 is what's taught in the book. It's the most commonly taught. But only problem with S1Q3T3 is it's only about 25% specific, or 25% sensitive. So in 75% of the patients with a PE, they won't have S1Q3T3. You won't see anything on the 12 lead, or you won't see that. And so it's not real sensitive for picking up those pulmonary embolisms. But still good stuff to know because they do talk about it in the book and possibly on a test. So with S1Q3T3, you have a deep S wave in lead 1. Got a big one. Looking down here at this one, you got a big S wave in lead 1. Q3, or Q wave in lead 3. Ooh, kind of messed up our thing there. You have a big Q wave in lead 3. Got that. And then T wave inversion in lead 3. And we have that. We have an inverted T wave down there in lead 3. So this does meet all the criteria for S1Q3T3. So another way that has been proven to be more effective is the inverted T wave in lead 3 and V1. This shows an 88% sensitivity, so it picks up 88% of PEs, and it is 99% specific, which is excellent. So if we look at lead 3, and we have an inverted T wave there, and then we look over at lead V1, and we have an inverted T wave there, which we do, those two indicators there together show us that we have a 99% chance that there is a pulmonary embolism going on, and it's going to show up on 88% of PEs will show this EKG abnormality. What do we do for PEs in the field? Not a whole lot. Lots of oxygen. Recognize it. Get them to a facility that can hopefully take care of it. Start a large IV so they can draw blood, do the D-dimer test, all that fun stuff, and give them blood thinners. We don't do a whole lot for it in the field other than recognizing it. Okay? And letting the facility know ahead of time that it's possible PE. Severe hypothermia may develop the J waves, also known as Osborne waves. So we got our wonderful J waves here. It is right here. It's at J point and kind of like an extra little wave. Almost, if that was in V1, you'd think it's a terminal R wave and show up right bundle branch block. But no, this is known as a J wave or an Osborne wave that you're seeing there. All right, kind of getting it everywhere, right there at the end of the QRS complex, that J wave. A lot of times with hypothermia, you are in a bradycardic rhythm. Your whole body shuts down and slows down, tries to preserve energy, and then it's possible to go into like an AFib or an A-flutter with that as well. But bradycardia is a big one with hypothermia. Electrolyte abnormalities or imbalances. Hyperkalemia, you get tall peak asymmetric T waves and then a flattened out P wave. And the taller it gets, the worse the hyperkalemia gets, the taller the P waves will get, or the taller the T waves will get, and it will also cause the widening of those QRSs. So let's look at a couple of them here. This is what we're talking about when we talk about peak T waves. You see how big they are up here in the top? And it's in a lot of leads. Pretty much every lead, except for these two, every other lead has a peak T wave that is as tall or taller than the QRS complex. So that is what we mean by peak T waves. As it progresses, you will still have a lot of those peak T waves that you see over here in these precordial leads, and you are having widening of the QRS. You see how wide that is? I mean, this is just getting ridiculously wide, and it's not good. You need to recognize that and start treatment for hyperkalemia and letting the hospital know that they're hyperkalemic. A lot of times when we go to dialysis centers and pick people up, we see this hyperkalemia because they missed dialysis or whatever. And, they might be in a really wide QRS, big peak T waves, and we know we need to start looking at giving them the stuff to lower the potassium. Start a breathing treatment on them, albuterol. Whenever they get to hospital, get the dextrose, the insulin, K-oxalate, all that fun stuff for hyperkalemia. Follow your local protocol, of course. But those are just some 12-lead examples for that. Brugada Syndrome is a genetic disorder involving sodium channels in the heart. Usually this goes undiagnosed and still somebody goes and sees a doctor for another reason and they do a 12-lead and then they'll be diagnosed with Brugada Syndrome. So with that you get an incomplete right bundle branch block, so we'll have those terminal R waves up there in the lead V1. You might have some ST segment elevation. It's going to go back to baseline pretty quickly though. It's going to look a little different than our STEMIs. And then you'll see that in V1, V2, and maybe V3. So let's look at the 12 lead here with Brugadas. So we have a terminal R wave there in lead V1, kind of leaning us towards possibly right bundle branch block. Our QRS is not greater than 0.12. You look up here, use a cheat sheet, 0.102. So terminal R wave, possible incomplete right bundle branch block, and then we have our ST elevation here and right there. So those two things, and you see how it slopes down quickly and comes back to the baseline relatively quickly. Those are indicative that it is a Brugada syndrome, not an ST elevation. So see how this up here screams acute MI suspected, ST elevation, consider lateral injury or acute infarct. Well, no, this is Brugada syndrome. This is a genetic thing. This is not ST elevation. So don't pay too much attention to that. I like to look at my 12 lead, come up with my own diagnosis, come up with my own, what I think it is, and then confirm it through my doc in the box up top. All right. Now, for anybody who's paying attention, there is a little bit of elevation right there as well in lead 1 and AVL. All right. But what we're focusing on here is the Brugada Syndrome and how you'll see that in V1, V2, and possibly V3. All right. Long QT syndrome. This is a QTC, which means corrected, exceeding 0.45. The heart experiences a refractory period that may cause ventricular dysrhythmia. So, with a QT, what's it mean? What is a long QT? So from the time that your Q wave hits or R wave, whatever it is right here, you measure that from there to the end of your T wave, right there. And as your heart speeds up, that it should shorten, and then as your heart slows down, it takes a little longer to repolarize everything. So if there is a long QT syndrome, it is going to show up, read your little numbers up the top of your 12 lead, QTC greater than 0.45 seconds. That puts you at a higher risk for like the R on T phenomenon or some other issue there. Some medications change that. There's a whole list of them. I don't think I put it on here. Oh, yes. No, I didn't. There's a whole list of medications that can cause this long QT syndrome. It could be just a genetic thing. Hypocalcemia can cause it. Acute MI can cause it. And pericarditis can also cause it. All three of those can cause this long QT syndrome, and it's just something to be aware of. So that you can pass it along that, hey, they might have a long QT syndrome, and they can be treated for that as well. So, STEMIs. Let's get into STEMIs a little bit. I don't think we have too many more left to go. Suspect STEMI if, this is according to AHA, leads V2 and V3 for men over the age of 40 is elevated more than 2 millimeters. If men less than the age of 40 is elevated more than 2.5 millimeters, or women of any age is elevated more than 1.5 millimeters. So looking at lead V2 and V3, if you have elevation greater than that, then that qualifies. And then greater than 1 millimeter of elevation in any other leads. So looking at the whole rest of your 12 lead, if you have elevation more than 1 millimeter in any other lead, those are your numbers that you're looking at for STEMIs. And that's according to AHA. So any and all elevation, you must have it in 2 or more contiguous leads, and you do not have to have reciprocal changes. So remember how we talked about IC all leads a little bit? So what does contiguous mean? That means you're looking at the same part of the heart. If you have V1 and lead 2 that both show, say, 3 millimeters of elevation, but nothing else anywhere else, that is not a STEMI. That does not qualify for a STEMI. All right? You have to have 2 or more contiguous leads. So if lead 2 and 3 both show 3 millimeters of elevation, or leads 2 and AVF, they are looking at the same part of the heart. So if both of those, you have to have those 2 or more contiguous leads. They look at the same part of the heart, and they have to have greater than 1 millimeter of elevation, except for right here. Those are the age-dependent elevations. I'm sorry, lead V2 and V3. You're looking right there. V2 and V3 have to be greater than 2 millimeters if you're over the age of 40. Under the age of 40 in a male, greater than 2.5 millimeters. And then a woman of any age, greater than 1.5 millimeters. All right. Clear as mud. Those are the numbers that we have to hit. 2 or more contiguous leads. Reciprocal changes are not required, so you don't have to have ST depression somewhere else in the 12 lead to prove that it's a STEMI. It is nice to see reciprocal changes on our side anyways. I guess if you're a patient, it's not good to have. But it is not required. this is just a nice little diagram here that shows the different parts of what you're looking at. So let's start here. Lead 2, 3, and AVF are the purple ones there. Those are looking at your inferior wall of the left ventricle. They are all fed by the right coronary artery in most patients. The 1, AVL, V5, and V6 are all looking at the lateral wall of the left ventricle. That is that outside wall of the left ventricle. They are all fed by the left circumflex artery. Lead V1 and V2 is that interventricular septum, and they are fed by the left anterior descending artery. And then the anterior wall of the left ventricle is viewed in V3 and V4, and they are fed by that left anterior descending as well. So, then moving over to the far right side outside the little box, I couldn't find a box, so I had to make my own. V4R is looking at that right ventricle. It is fed by the right coronary artery. V8 is the posterior of the left ventricle, V8 and V9 actually. Posterior of the left ventricle. It is fed by the right coronary artery and that left circumflex. So that's why it's important to do those 15 leads. You know, if you're suspecting possible MI and your 12 lead looks good, pop those extra 3 leads on there, V4R, V8, and V9, and you're just taking off. You know, you just unattach these and then move them over here and then relabel them whenever you print out your 12 lead. Okay? So, some STEMIs. What do we see here on the top one? What do we got? It's kind of a basic STEMI here. Lead 1 looks good. V2, V3, AVF, all 3 of those have elevation. AVL has nothing. AVR is negative. V1, 2, and 3 all look pretty normal. V4, 5, and 6 all look fairly normal. Maybe slight depression there in V4, V5, not really enough to notice. So what is this going to be called? This is going to be an inferior wall MI because we have elevation in leads 2, 3, and AVF. We do have more than one lead that is contiguous. We have greater than 1 millimeter of elevation, and we do not have reciprocal changes. So, like I said, reciprocal changes are not required. Nice to have, not required. So, we're going to go ahead and call this a STEMI. That right coronary artery is, in fact, blocked. Go ahead and pop on our 15 lead, do V4R, V8, V9. Chances are we're going to see a right-sided and a posterior wall MI as well. And those will show up with ST elevation, and they'll look just like the rest. Now, the bottom one, what do we see here? Lead 1, 2, 3, maybe slight depression there in lead 2. Then AVF, AVL, AVR. You got, looks pretty good, AVF, maybe slight depression. V1, V2, V3, V4. All of those have a lot of elevation, so what's that telling us? That is going to be V1 and V2 are our septum, and then V3 and V4 are our anterior wall. Both of those are fed by the left anterior descending artery, so we've got a blockage in that artery someplace, and it's going to be pretty high because it's hitting both areas of the heart. Again, we don't really have, we have a little bit of reciprocal changes, I guess. Yeah, so it's good to know where in the heart, of course, you need to know where in the heart it's happening and then what blood vessel is being affected by that. Okay, let's look at this one. Lead 1, got some ST elevation. All right. Lead 2, no. Lead 3, no. AVF, no. So our inferior is good. What we do have is this wide PR interval. Different there, different there. That's odd. Almost looks like got one there, one there, one there, gradually widening out. Another one there, it's dropped. And then widening out again until it drops another one here. What are we going to call that? What's our underlying rhythm? This is going to be a second degree AV block. What type? Going, gone. Type 1, second degree type 1 AV block. All right, back to our STEMI identification. So we got some elevation in lead 1, got some elevation in lead AVL. Looking over here, got some elevation V5, V6. So this is all of our lateral leads, V5, V6, 1, AVL. All of our lateral leads are saying elevation greater than 1 millimeter. So that tells us that it's our left circumflex artery that's affected. And it's hitting that whole lateral side. Go ahead and pop on our 15 lead, V4R, V8, V9, see if that posterior wall is affected some. Probably not so much the right side, but possibly that posterior is going to be affected as well. At least in some form, maybe not a bunch, but some. Okie dokie. Bottom one. Let's look at that. Lead 1, maybe some ST depression. Lead 2, looks pretty good. Lead 3, got some ST elevation. Lead AVF, got some ST elevation. And you might have a little bit there in V2, or lead 2. AVL, got some ST depression. AVR looks good. V1, ST elevation. V2, no. V3, yeah, maybe a little bit. V4, V5, V6 all look all right. V4R, so they did at least I guess a 13 lead on this one, and it shows elevation. So 2, 3 AVF, at least 3 in AVF, that shows our inferior wall is being affected. V4R kind of confirms it, that it is that all of these are fed by the right coronary artery. So we do have right ventricular involvement. Do have some reciprocal changes there in 1 and AVL. So that's going to be another STEMI that we're looking at. Let's talk about STEMIs and left bundle branch block. I found this online. I take no credit for making it. It is a great little thing. So whenever we look at STEMIs and left bundle branch blocks, we look at the modified Scarbosa criteria. The Scarbosa came out, and then they adjusted it, and now they come up with this modified Scarbosa. I don't remember the particular numbers of like sensitivity and specificity, but it is very high, and it's a good one to look at. So, left bundle branch block. Remember what we talked about on that. Looking at V1 of our 12 lead. Let's just use this 12 lead as an example. If we have a terminal R wave, terminal S wave, in lead V1, and that QRS is greater than 0.12. So if this is real wide and we have a terminal S wave, then that means we have a left bundle branch block. All right. Then if you get ST elevation with that, you must meet these criteria. Anytime you have a left bundle branch block, it really throws things off. And so that's why we have to go by the Scarbosa criteria to then identify the actual STEMIs with those. So let's start at the top. Hemodynamically unstable or acute heart failure. If you get that, if those patients have that, yes. And you can answer yes to those. They need to go to a facility that has some sort of thrombolysis or PCI, something like that. Some sort of a little bit higher level care, at least have a cardiologist there. All right, so if they're hemodynamically unstable or acute heart failure and you answer no to that, you move down to Scarbosa criterion 1. So you have concordant ST elevation greater than or equal to 1 millimeter in any lead. All right, so in any lead that has a positive deflection, and we're looking over here on the side, any lead that has a positive deflection has greater than 1 millimeter of ST elevation. Then yes, and you're done. You get that, you're done. You call it a STEMI, and you send them on to a cath lab or whatever. So I'm going to kind of go back and forth between these two. So if, assume this bottom one has a left bundle branch block, then if you had ST elevation greater than 1 millimeter in any of these positive leads, where it's mostly positive deflection, then you would call it a STEMI. If you had ST elevation here and those negative leads there, that would not qualify, okay? ST elevation has to be with a positive deflection there. Concordant ST elevation greater than or equal to 1 millimeter in any lead. I know discordant and concordant, you kind of forget about those things, but that's what it is. So, if you meet that, you're done. Call it a STEMI, go on. If you do not meet that, so you look around, doesn't have any of that, then you can move down to Scarbosa criteria 2. So you have concordant ST depression greater than 1 millimeter in leads V1 through V3. So remember we said these are normally negative deflection anyway. So if you have ST depression with this greater than 1 millimeter in those negative deflected leads, V1 through V3, then you call it STEMI. Got it. All right. V1 through V3, ST depression greater than 1 millimeter, and that negative QRS, you're done. Call it a STEMI. Take them on. So if you don't meet the first two, say, nope, don't got that. We move on down to Scarbosa criteria number 3. So if you have excessive discordance and the STS S ratio greater than negative 0.25, have fun learning that. But what is important on this is if you are looking back at your different leads there, if any of your negatively deflected leads, like V1 through V3, have ST elevation greater than 25% of the height. So if you measure this out, and this is, say, 20 small blocks tall, your ST, or your ST depression there, your QRS wave there is negatively deflected 20 small blocks, and then you look over here at your ST elevation, and it is more than 25%, which would be 5 small blocks. If that ST elevation is greater than 25%, then you call it a STEMI. All right? So, concordant ST elevation greater than or equal to 1 millimeter in any lead, positive deflection, and 1 millimeter, calling it STEMI. Negative deflection in leads V1 through V3, ST depression, and that negative deflection there greater than 1 millimeter in V1 through V3, calling it STEMI. Negative deflection there on your QRS, and then greater than 25% of the height of ST elevation, and hit that, you call it a STEMI. Any of those three you hit, you call it a STEMI. Take them someplace where they can get STEMI treatment, okay? That kind of breaks it down, keeps it pretty simple. Feel free to screenshot this or record it or whatever. Maybe we can get it out to everybody so they can keep that in mind. Diagnosis, this is a modified Scarbosa. This is the easiest way I've found to keep track of it. All right. Let's talk about nitro for just a moment here. So we want to keep in mind what nitro is. It is a vasodilation drug. It increases blood flow to the coronary arteries and the myocardium. That is why we use it. Vasodilation, increased blood flow. It also causes peripheral vasodilation to reduce preload and afterload on the heart, which can be a good thing, and reduce myocardial O2 demand. But it can also decrease preload and afterload, and that can be a kind of a catch-22. So, indications for it, some chest pain, hypertension, CHF exacerbation, pulmonary edema. Any of those things are indications for it. Contraindications, and this is what I really want to touch on. Right ventricular infarct. If you have a right ventricular infarct, that right side of your heart cannot pump efficiently, and you do not want to give nitro because it causes that peripheral vasodilation and decreases preload. When you are having a right ventricular infarct, you are relying on preload in your body to fill that right ventricle and keep pumping blood through your lungs and back into the left side, all that. So you want to make sure you are ruling out right ventricular infarct prior to giving nitroglycerin. Sometimes your basic kind of gets ahead of themselves. Maybe they try to give nitro before you get your 12 lead or whatever it is. Make sure you get that nitroglycerin or that 12 lead first, and you rule out right ventricular infarct. All right. Another contraindication, hypotension. According to the book, it's less than a systolic of 90. I like to use personally a systolic of 100 just to keep me safe. Any suspected bleeding in the body, because it's going to vasodilate and make it worse. And then erectile dysfunction drugs in the last 2 days. It's a good rule of thumb. I think Viagra you can do 24 hours, and Cialis and the other one is 2 days. But 2 days is a good rule of thumb. Dosing, 0.4 milligrams spray every 5 minutes, up to 3 total. You want to try to get an IV before you give it, just in case it tanks their blood pressure. You can hit them with a little fluids, bump them up a little bit. And like I said, don't let your basic get too far ahead of you. Get your 12 lead first, get your IV first, and then start giving them the nitro, assuming there's no right ventricular infarct. Just so you know, of course, all this information came out of your textbook. And then check out this website. It's really good. It's called Life in the Fast Lane, litfl.com. They have a lot of resources on there. It's all EKG based. Well, not all of it, but a lot of it is EKG based. Anything you want to know about EKGs and looking at rhythms, lots of practice stuff on there. It's a really good resource. A lot of the 12 leads that you see in this presentation came out of lifeinthefastlane.com. So there you go. Hope this helps kind of clear things up with 12 leads and 15 leads. Gives you all a little bit deeper understanding of it all. Of course, any questions, comments, whatever else can be directed towards me or Curtis. Have a good day.